I'm Carmen Howarth. I'm presenting the complex case study for XNH480. The patient summary includes the medications as well as a principal diagnosis. My patient is a 57-year-old male that was an ex-Army tank officer. His current diagnosis includes post-traumatic stress disorder, anxiety and depression, sleep apnea, and he also suffers from erosive esophagitis. So he has excess stomach acid. His medical history includes cervical and lumbar spondylitis, as well as atrophied spinal erectors and atrophy of the upper and lower primary muscles. His medications are listed in the written document. However, the medications include antidepressants that help with the anxiety attacks, the pain, the reflux, and non-steroid medication which helps with inflammatory issues. So his complications include unable to relax, he has nervousness, sleep apnea, and he's also in chronic pain. He presented to the clinic for well-being, wanting to improve his general well-being and wanting to improve overall strength in his back and his legs, as well as wanting to lower the medications for his pain, which is something you're going to have to discuss with his doctor, but we can certainly help with that. He's currently undertaking hydrotherapy twice a week, and he's also undertaking golf and also has 2 teenage children. The assessments that we looked at were the 6-minute walk test and the grip strength. So in the 6-minute walk test, you can see the improvement over the time for his age group. The grip strength was also showed some improvement. However, it was just mainly a predictor of body strength, and that mean was in relation to males up to 25 years. We also did some range of motion testing. So we tested the knee flexibility as well as extension. So in the flexibility, his left side, obviously we had a deficit compared to the right side. And what we did was have the client lie prone on the bench, and then we measured with the goniometer the amount of flexion that he had on each side. So as you can see from those results, he had more flexion in the right side than he had on the left. We also used a RPE pain scale to get an idea of the level of pain and also just the rate of perceived exertion in relation to the Borg scale. We know we can measure pain by using the Olwestry pain scale for lower back, or by the patient informing us and clinical observation. We can use questionnaires to confirm anxiety and depression or PTSD symptoms. We know we can use the range of motion techniques and measures to confirm limitation in joints and muscles. So how do we measure post-traumatic stress disorder? A current study examines the potential role of physical activity as a moderator of the pain and the PTSD relationship. Here they say that physical activity in itself can alleviate the pain threshold. Essentially though, this is not a measure, and that's what I wanted to assess primarily. Therefore, my supervisor and I decided the best moderator to use as a conservative measure is a patient-exercise physiologist relationship. Using rapport as a measure defines the complexity of this case. We're then building rapport and trust in order to prescribe suitable exercise for both the musculoskeletal issues as well as to be able to treat the post-traumatic stress disorder, including the anxiety and depression, was the key to being able to help this patient. Research shows physical activity may prevent post-traumatic stress disorder symptoms by releasing chemical endorphins or happy hormones into the brain. So the exercise prescription we utilised were mindfulness, breathing techniques, aerobic for cardiorespiratory fitness, resistance training for strength, and building rapport and having empathy for the client. In general, we wanted to reach the goals that he wanted, which was well-being and building strength. Mindfulness-based stretching and deep breathing exercises normalizes cortisol levels, and reduces PTSD symptoms, severities among individuals with some subclinical features of post-traumatic stress disorder. It improves memory and performance, accompanied by normalized glucose metabolism in the limbic system. The prescription consisted of isometric stretching, so just your normal stretching in a chair and holding that stretch for 20 seconds, which an individual can do on their own, or through proprioceptive neuromuscular facilitation, as we like to call it, PNF stretching. This is an advanced form of flexibility training that involves the clinician as well as the client, and involves both the stretching and contraction of the muscle group which we're targeting. So if it was the hamstring, we'd target that area. What that does is increase flexibility and strengthen the muscle. Deep breathing exercises were also incorporated throughout the resistance training exercises. We know that deep breathing lowers heart rate, lowers blood pressure, relaxes the client, increases cardiovascular capacity, and endorphins are released. So what we did, like for example, was inhalation during the eccentric portion of the set exercise and exhalation during the concentric phase. So when you're pushing the weight away from you, you want to take those slow breaths out, and when you bring it back in, a deep breath in. Other forms of deep breathing exercises include Tai Chi, yoga, and Pilates. Aerobic exercise was also used for cardiovascular fitness. We used a warm-up on the upright bike and a cool-down. We also used the step-ups and the sit-to-stands. Resistance training for hypertrophy and strength included leg extensions, leg curls, upright rows from the TheraBand which progressed to the cable, as well as a unilateral leg press to help dendrite growth in the knee area. We also use those breathing exercises throughout these exercises, as we said before, to help the post-traumatic stress disorder. On self-reflection, we should have probably measured the girth, maybe had some more open-ended questions and related to the PTSD. I looked at the questionnaires and the results said the same thing: be non-competitive, don't change the routine, be empathetic, and build rapport, which is basically what I've derived my prescription from. The education I provided was more about rest and making sure that he did have some rest in between muscle growth, and probably not to overdo it. I probably could have given him more education in regards to exercise and post-traumatic stress disorder. Any questions?